I guess I just want to thank you for even thinking to invite me to be a part of your class and your conversations, especially knowing that your students are really out there doing frontline work right now and taking this class and probably managing your own family obligations and all the other things that are a part of your work-life balance right now. So thanks for inviting me to be a part of the conversation. Yeah, so my role is I'm here at Central Washington University. We have an undergraduate degree, a Bachelor of Science in Public Health. That program is on our campus, although not currently, we're all virtual, but we have a campus-based program, we have an online degree program, and then we have graduate level programs in public health, so a certificate and a Master of Public Health. So my role is to direct those programs, so I am the advisor, the academic coordinator, and then I also teach many of the courses. But I'm also a researcher in public health and a practitioner, and I really care a lot that the work that we are doing in communities is reflected in the classroom, and vice versa. What we're learning in the classroom is reflected in practice. So it's really important for me to think about the crossovers, like you talked about, between the academic side of the house and the actual practice community side that's affecting real people's lives. How did I get to public health? I think that was your question, right? Yeah, so I ended up in public health a little bit backwards. I actually wanted to start in the clinical professions. I wanted to go to medical school, and then I thought about physician assistantship. And eventually I started learning about some gaps in the health system that I was observing or experiencing, and noticing that those gaps could better be solved through the lens of public health and through prevention rather than waiting until things were exacerbated or ended up in the emergency room or ended up in a place that required high cost, high specialized treatment. So I was really interested in the idea of upstream factors and looking at prevention and social determinants of health. And those were the concepts that really spoke to me. And I know that there are amazing clinical people out there doing the important work of treating individuals, and I really wanted to be a part of looking at the health of populations from a prevention standpoint. So that's how I got involved. My undergraduate degree is in economics, and my master's and my doctoral degree are in public health. So I made that transition after undergraduate level work to graduate. I'm a maternal and child health researcher, and that means I study everything from before baby through infancy and even into adolescence, and that whole continuum, so that health, we know health starts before baby even gets here, and so that kind of reproductive life cycle is a part of my work. I really focus on family planning and access to reproductive health services as individuals are making decisions about if they would like to start a family, how they do that, having the access to information, education, support, and services to really help them through that transition. So I also focus mostly on, what we call vulnerable populations. So whether they're vulnerable by virtue of their socioeconomic status, their geographic location, right? Urban and rural communities face very different challenges in terms of their access to care. Racial and ethnic minority groups, again, face, unique challenges. And so I focus mostly on those communities that, face traditionally underrepresented barriers. I have taught, population health assessment courses where we do community-based assessments. One of the ones I did the first year I took this job, I've been here almost 7 years now, and our first class really we did a partnership with the county to look at the built environment, right? So our sidewalks and our stoplights and, you know, pedestrian crossings, and, you know, what are the things about our built environment that are either, you know, favor population health, or maybe make it challenging to get outside or to, you know, be physically active because maybe the sidewalks are in really bad shape, or maybe there isn't a pedestrian crossing where there should be. So we mobilized our students to go out, and they literally walked all over the county. They took pictures, they, you know, took notes with their clipboards, and they noted where the places, you know, the actual physical places around our county that had either needed maintenance, right? So actual physical disrepair, or they just had ideas for how to improve the built environment so that people could get outside and, you know, walk or bike or be physically active. So that's an example of a community assessment that we mobilized our students to do on a county level, which was pretty exciting. I guess I'm working right now on a project, again, looking more at reproductive health access, and I mentioned a little bit about the differences between rural and urban locations, and how important it is that we don't just conflate things on a state level or even a county level, right? We live in, right now I live in an area that's very close to an urban center, but it is not urban at all. And oftentimes when you look at our region, the data looks like it's combined. But the reality of those, you know, two areas is very, very distinct. So I'm working with a student right now to collect some survey data on how individuals, women in this case, are accessing reproductive health services in those two very distinct geographic regions. So that's just another example. Shortage of the workforce in general is incredibly important. It's something that I've always had concerns about, you know, for really the last decade, that we were moving into this space of, you know, we were facing some major shortages, and, you know, that's becoming more clear that the disparity between rural and metropolitan areas in terms of the health workforce is a big problem. And I think, you know, we've seen facilities completely closed down in rural areas, they're closing entire service lines. And you talk, you know, my work in maternal child health, there are hospitals that have completely gotten rid of their OB units. And that means that now moms are having to travel, you know, 40, 60 miles to get OB care. So there's real problems when we look at the rural disparities that exist, really all over the country, but especially where I live. I think one of the big failures is that we have had a history of underfunding, chronically underfunding our public health systems. And for those of you that don't know, public health funding typically flows from a number of different sources, but usually from federal government to states, and then states allocate resources to the local public health jurisdictions. So typically those are local county government, right? Yeah. So maybe where you are, it might be your county is the local health jurisdiction. Where I am, the surrounding areas, it might be 2 or 3 counties get together and they become the local health jurisdiction. And then some other areas, it's this municipality, it's the city. So depending on where you are, those local public health jurisdictions are the ones that are really doing the primary response to any kind of local outbreak, or in this case, a widespread outbreak. But we have chronically underfunded those local public health jurisdictions. They've faced a series of funding cuts for really years, if not decades, right, that have been building. Staffing shortages, staffing turnover, the whole infrastructure has been really challenged. And so I think if we're talking about the future of public health, we have to reinvest back at the local level and a coordinated approach up on through state and federal government. So it's not impossible, but we have to, I think, dedicate our energy and our time to thinking about how we reallocate resources back into the public health infrastructure. And that has to happen before we get to crisis, because once we're in crisis, it's too late, right? That's why we're facing a lot of the problems we're facing now, is because we didn't have a testing system that was ready to go, till March or later, and we still don't see testing infrastructure in place. So I think, one of the other things about public health that's so interesting that I've been observing as a phenomenon is that when things are going well, and when public health is fully funded and doing their job and active, you don't really hear much about it because we're doing our job to prevent disease, or we're doing our job to keep people healthy. But when we see these big outbreaks, or when we see these big events, that's when we start to pay attention to things. And unfortunately, there's been a gap between when things go well and when things are in crisis. And if we don't stay on the, prevention side of things, that's where we see the gaps open up. And so I hope that what this whole event is making us, or is revealing for us, is that we should be realigning our priorities into prevention of disease and keeping people on the health side, promoting health, rather than just chronically responding to outbreaks and crises and things when it's too late to do anything about, right? We really have to shift priorities. So that's what I'm hoping people are paying attention to, and that we start to see a better reinvestment into those things that we know will prevent serious issues. Epidemiologic terms are a part of our vernacular, right? So there are some bright spots, I think, for us to think about even in this pandemic. Social determinants of health component, and the fact that our health isn't only determined by our biology or the genetic factors that predispose us to certain conditions or not, and it's not only affected by our individual behaviors. So a lot of times when I work with my students who are just coming into this program, and they say things like, well, if you just teach people to eat better, then they're going to have better nutrition behaviors or physical activity behaviors. If you just teach them, the right way to eat and the right way to be physically active, then they can do it. And the reality is that when we make those assumptions, we're leaving out a whole host of other variables that are going to affect someone's health outcomes. So things like your neighborhood, right? What neighborhood you live in, and whether you have access to grocery stores or other sources of produce and healthy food, or do you have to travel 10, 12, 15 miles away to access that? And do you have to use public transportation? Do you have your own vehicle? Do you have access to an income that allows you to make those purchases? Or are you incentivized to purchase other things because you need to make your income stretch, right? So there's a whole host of other variables, the things we call social determinants of health, the things that exist in our social environment that play a huge role in individual health outcomes and community health outcomes. And those are the things that I think if we can create a narrative around that, not only for those of us that study public health, right? We kind of get it, but in translating it to anybody who plays a role in interacting with the public, our healthcare providers, our school teachers, our businesses, if they understand that concept of social determinants of health and the important role that it plays, that's where I think we get the innovation to solve some of those problems and create more opportunities for maximizing health. I am so glad that you're talking about motivational interviewing. It's a big strategy we use in health promotion, and not just not just interpersonally, but also on a community level, right? How do we listen to the needs of a community from their voice, from their perspective, rather than I think sometimes it can be easy for those of us in academia, at least, right, to go into a community and say we're going to do good by identifying all their health problems, and here's all the, the issues that your community must be facing. But that can be really grating on a community, to have these outsiders, like me, come in and say what's wrong with your community, rather than coming together and saying, I want to hear from you. What are your priorities? What would make your lives better? How can we help build skills or opportunities to maximize health that resonate with your community, not that are coming from these scientists or these researchers on the outside, but how can we build that capacity from within a community? The beauty of finding the synergies between what we're all doing, right? In different ways, and we apply different lenses on things. But for the most part, if we can find common values across our disciplines or across our sectors, that's where the potential for really meaningful collaboration comes. The future of, addressing population health, I think that's where it is where do we find the synergies, the common strengths, where do we build on that, so that we can really make the biggest collective impact that we can. Just 1 minute